Welcome everyone to our NephCure webinar today on improving health outcomes in nephrotic syndrome and the role of eHealth. My name is Kelly Helm, NephCure's Executive Director of Patient Engagements. I will be your moderator of today's educational webinar. And today our wonderful physician speaker will be reviewing the latest research on nephrotic syndrome, the challenges of managing nephrotic syndrome, and she will also introduce us to some new research about how technology and the use of eHealth may help improve our loved ones or our own health and health outcomes. Real quick, before I introduce our speaker, I would like everyone to know that we will offer a question and answer session at the conclusion of the webinar. From questions submitted to the Q&A section on your Zoom toolbar. So you'll find that button usually at the bottom of your Zoom toolbar, sometimes at the top, but feel free to type in your questions throughout the webinar, and we'll get to as many of those questions as possible at the end. And then also, if we don't get to all the questions, we can follow up and get you the answers after the fact. So now I would love to introduce our speaker, Chia-Shi Wang. Dr. Chia-Shi Wang is a pediatric nephrologist and associate professor of pediatrics at Emory University. She received her medical degree from Wake Forest School of Medicine, where she also completed a pediatric residency. Dr. Wang completed a pediatric nephrology fellowship and received a master's degree in clinical research from Emory University. She currently serves there as the co-chair of the pediatric working group in Neptune and the co-chair of the American Society of Pediatric Nephrology Research Committee. She's clinical and research focused in glomerular disease and the use of electronic health tools for chronic kidney disease management. Thank you so much for being here today, and we're excited to learn from you. So I'll let you go ahead and share your slide deck and take it from here.
Thank you, Kelly, so much for that very kind introduction. And it's absolutely my pleasure to be here to speak with everyone today on improving health outcomes in nephrotic syndrome and the role of eHealth. Can you see my slides okay? Is it in presentation mode?
Yes, we're good to go.
Perfect. So as Kelly mentioned, I work for Emory University and Children's Pediatric Institute in Atlanta, Georgia. And I have a couple of disclosures. First, I have research grant support from National Institutes of Health, and NephCure Kidney International also is kindly supporting my research working with CureGN. In today's talk, I will be discussing an unapproved or off-label mobile app, or Your App. I'm one of the creators of Your App, but I do not receive any financial compensation related to the use of this app. In today's talk, my goals are first to hopefully help you recognize the complex interplay of biological and environmental factors in nephrotic syndrome management. You've probably heard from your kidney doctors and the experts here at NephCure, we can't pinpoint an exact cause of nephrotic syndrome. Instead, we think it's a group of factors that may come together that produces disease and affect your well-being. And because of this complexity, our treatment and management is equally complicated. And my second goal is to help recognize the importance of self-management support, supporting everything that you do for yourself and for your loved ones at home, and how important it is for our nephrotic syndrome outcomes. Finally, I hope to illustrate ways in which electronic health or eHealth tools can support nephrotic syndrome care. So starting with the definition of nephrotic syndrome is defined by 4 key features listed here. And starting with the top box, nephrotic range proteinuria simply signals to your doctor that you're spilling a substantial amount of protein and losing it from the body into the urine out of your body. And this reduces in low protein levels in your blood. And medically, we call that hypoalbuminemia in your box to the right. And this then leads to edema or swelling that we can see. Something that we can't see, but nephrotic syndrome also produces is hyperlipidemia, and that is high cholesterol levels in your body. And you can tell by this that nephrotic syndrome simply describes some signs and symptoms that we see. It doesn't really tell us the underlying cause of the condition. And so in the next few slides, I'll go over what we know about how nephrotic syndrome is developed, also known as pathogenesis. Here's a picture of your kidneys, and we all have 2 kidneys, and each one is about the size of your fist. And what happens is that the kidneys receive blood pumped by the heart through the big arteries, and the job of the kidneys is to filter this blood. Inside each one of the kidneys is about 1 million filters crammed in there. So they're super, super delicate. And these filters act to keep back everything good that you want to keep in the blood, everything you want to keep in the body, like proteins, and excrete out all the waste and extra water that you do not want. And so in nephrotic syndrome, it is the filters that are becoming injured. And I hope you can see my cursor here. On the left is a cartoon depiction of one of these filters. And remember, you have about 1 million in each kidney. And you can see that the blood is being pumped against this filter, which has several different layers. And the filter keeps back all the protein inside the blood and excretes out the urine. And on the very outer layer of the filter is this cell called podocyte. And this podocyte is very important in nephrotic syndrome pathogenesis. To the right are pictures, microscopy pictures of actual kidney tissue. So here, imagine you are up here in the urinary space, and you're looking down onto the podocytes. So here, I'm looking down onto a podocyte, and the scientists have color-coded them. This one single podocyte cell is colored in brown. You can see they give off these extremely delicate, fine projections. And then this sub-branches into these very, very tiny branches. And this is called the foot process. Remember, this picture is a scanning electron microscopy picture. So we're looking at something that's been blown up more than 10 million times its size. And so these super microscopic foot processes also interdigitate with the foot processes coming off of other podocytes. So here's one in brown with its branches kind of interdigitating with the branches coming off of this one cell in purple, this third cell in green. And you can see that this forms an incredibly intricate mesh. And this mesh is the final outer layer of your filter that keeps back the protein. Here's a picture of it cut kind of crosswise, and you can see the foot processes really standing tall. They are shoulder to shoulder with one another, but the spacing is extremely discrete and very precise. And this is what controls the filter's ability to keep back super tiny proteins. So on the next slide, so the common feature we see in all nephrotic syndrome patients is that something has injured the podocytes. So on the left is a normal microscopy picture of normal kidney tissue. And on the right is what we would see in a patient with nephrotic syndrome. Here you see kind of the podocytes kind of peeling off of the filter, the outer edges of the filter. And their podocytes are no longer kind of evenly spaced and standing up, they're flattened. And some of them, it looks almost disintegrated. The podocyte processes are falling off of the filters. So we've lost this final barrier. And so the question is, in nephrotic syndrome pathogenesis is what causes the kidney to start looking, go from something on the left to something on the right. And I've mentioned that this pathogenesis is not straightforward and it is quite complex. And here I've kind of summarized all the various groupings of factors that may be involved. So starting with the podocytes, is it something going on with the podocytes themselves? Is the podocyte formed differently, making it more susceptible to injury and disintegration? If so, what's causing that? Is it because of our genes? For some reason, the podocytes are just formed differently because of our genetic differences? Or is something attacking it and injuring it? Could it be our immune system? There's certainly evidence of that because we know most of our medicines work on the immune system and they seem to work for the majority of our patients. If it's the immune system, what made the immune system behave like that? Is it again something going on with our genes? Or is it something in the environment triggering the immune system? If it's the immune system attacking our podocytes, how does it do so? Does it produce certain factors that harm the podocytes? Are these factors coming from the environment that perhaps have triggered this whole cascade of events? So in the next few slides, I'll go over kind of the evidence and that we have for factors being implicated in each of these domains. So I'll start with genetic and podocyte factors. So here is a cartoon depiction of one single foot process. And what the scientists have found is that these letters are all letters of different proteins that are encoded by our DNA. And we know now that there are more than 80 genes that if disrupted, it can lead to nephrotic syndrome. And when I first started medical school, we memorized like 8 genes. Now there are more than 80. So we're learning more and more. And most of these genes, they encode protein that form the structure of the podocyte. Remember how important that structure is? This is a super specialized cell. And so it makes sense that if something is affecting how stable this structure is, that it would produce nephrotic syndrome. Other genes, their job are to affect channels on the podocyte, and channels are the main ways that a cell interact with the environment. And I'll go over the significance of that in more detail later on. So mutations or differences in these genes are important causes of steroid-resistant nephrotic syndrome in children, making up a great majority of our very, very young children. And we're also finding more and more that there are mutations that are also seen in adult patients with nephrotic syndrome. So that makes sense for steroid-resistant patients because, it makes sense if you have a mutation, then our steroids that target the immune system shouldn't work in you. But what about steroid-sensitive patients? Well, there's actually also evidence that genetic factors may also be involved in steroid-sensitive nephrotic syndrome. And why do we think that? First, we know steroid-sensitive nephrotic syndrome can run in families. I have several pairs of patients with a parent that have also had nephrotic syndrome in the past. And there are also differences in how common or how severe nephrotic syndrome is by race and ethnicity. So here's a study that we did, a meta-analysis of 26 studies conducted around the world. And what we found is that nephrotic syndrome is much more common among Black and Asian patients. And we know Black patients have increased risk for FSGS. So maybe there is something to the fact that it has something to do with our genetic makeup. And this other study, it's incredibly important. So this study looked at of 5 large cohorts around the world again. And this study, they looked at the entire DNA sequencing of these individuals. And what they found is that there are subtle differences in how the HLA is coded by DNA, and I'll talk about HLA in a little bit. And some of these differences increase your risk for nephrotic syndrome or are deleterious to you, or some of these differences protect you against nephrotic syndrome, so you're less likely to develop nephrotic syndrome. And importantly, these differences come up in different ethnic groups. They differ by ethnicity. So this may explain the clinical observation that we've made, which is nephrotic syndrome incidences differs by ethnicity. Here's kind of some genetic basis for it. The second main point of a study like this is that HLA molecules are molecules that help your immune system figure out what is self, what is your own body's cells versus what is foreign and shouldn't be in your body. So for instance, if you have a cold and you have a virus in your body, the HLA molecule signals to your immune system, go attack this. This is foreign. This should not be here, versus don't attack these cells. These are your own cells. So that so it's incredibly interesting that we see differences in HLA molecule coding with nephrotic syndrome risk. So that tells us there's a very complex interplay between your genetic makeup, how that influences your immune system and lead to nephrotic syndrome. So this is summarized here in this cartoon. So again, differences in your HLA molecules determined by your genetics leads to a difference in how your immune system behaves that then lead to nephrotic syndrome. And so what evidence do we have of the immune system being involved? We have plenty, and I won't go over these slides in detail, but except to say that we know T cells are upregulated. There are markers that T cells are upregulated in nephrotic syndrome. And conversely, regulatory pathways that control T cells are disrupted in nephrotic syndrome as well. We also have evidence that B cells are also involved. When we treat our patients with targeted therapy, for instance, like rituximab, which specifically act on the B cells, oftentimes it is effective, especially in our patients with steroid-sensitive nephrotic syndrome. We have other markers of increased B cell activity, and importantly, we have more recently found antibodies which are produced by B cells in nephrotic syndrome. So here is one of the most important papers that have been published in nephrotic syndrome research. So This paper published in 2009 by Dr. Beck et al. Found antibodies against a molecule called PLA2R in the kidney is increased in membranous nephropathy. And you know, membranous nephropathy is the leading cause of primary nephrotic syndrome in adult patients. These are complicated figures, but what it shows you is that PLA2R in red here is lighting up in kidney tissue. Then there are these antibodies that are lighting up and they seem to be targeting, they're right on top of the PLA2R. And this antibody is very, very high in patients with active membranous nephropathy. So this really advanced our understanding of one of the leading causes of nephrotic syndrome in adults. What about in children? So this is one study, very exciting, that utilizes the Neptune Study Network. And if you are your loved ones as part of the Neptune Study Network, thank you so much for contributing your information to allow us to do studies like this. So in this study, we found very excitingly that antibodies are also found in children with and adults with minimal change disease. And you know that minimal change disease is the top diagnosis in our children with nephrotic syndrome. And I want to show you here on the right, if you remember this picture of the genes involved in nephrotic syndrome, very interestingly, the antibody targets this molecule. And I don't know if you can see my cursor. This molecule, nephrin, is a molecule that it provides a bridge and maintains that perfect exact spacing between the food processes. And you can imagine it makes sense if you have an antibody that attacks that molecule, that it would result in nephrotic syndrome. So, so here's this cartoon summary again. We talked about some genetic differences leading to disruptions or differences in how your immune system may react. Now we are talking about what the immune system produces, or also known as circulating, soluble, or permeability factors, and how they interact with your podocytes and may cause injury. If you remember, we mentioned some of the podocyte factors are receptors. So sometimes these receptors may interact with these soluble factors differently, and that make them more susceptible to injury. So zeroing in again on the circulating factors, what's our evidence that the circulating factor is at play? We know that if we remove blood and plasma from a patient with nephrotic syndrome and inject it into animals, it can cause nephrotic syndrome in animals. So something's circulating. It's not your blood cells, not your immune system per se, or the podocytes. We also know that when we transplant our patients with FSGS, unfortunately, even a new kidney without podocyte injury or podocyte issues, they can get FSGS right away, again, probably because of something circulating in the blood. So I've already mentioned to you these autoantibodies. Two main ones that have recently been implicated are anti-nephrin and anti-PLA2R. There are other soluble factors, circulating factors, that are also being examined. And so we've mentioned this cartoon several times now, but at the very top are environmental factors and how they may trigger this entire cascade. And what's our evidence, or why do we suspect environmental factors at play? First is that in twin studies, remember, twins have the same exact DNA, so they would have the same podocytes, the same immune system, but sometimes one twin develops nephrotic syndrome and not the other twin. So it must be something in the environment that one twin has been exposed to, but not the other, that has produced and resulted in nephrotic syndrome. So we also have some suggestions that some food sensitivity issues may trigger nephrotic syndrome. There's a gluten-free trial that results are currently pending. There's also suggestion that infections trigger nephrotic syndrome and cause relapses and steroid dependency. Nephrotic syndrome generally, most of the time, is more common in winter months. So again, suggesting a link with winter infections. I want to point out a negative relationship, which is we've looked and we've studied this, and we found that vaccinations do not appear to be associated with disease relapse. And I believe this is important because we know that infections can worsen nephrotic syndrome. So we really want to protect our patients with vaccinations. So I want to so definitely this is a question that we want to examine. And thus far, all of our research suggests that there's no association between the two. So hopefully that was informative to you and helpful to realize at least the complexity of nephrotic syndrome. And so, of course, our treatment and management is also very complicated. And here, these next slides are, I'm sure I'm describing something that is very familiar to you already, which is first, our patients and families follow very complicated treatment regimen and with very significant side effects. Our steroid courses are extremely high dose, very long, and the dosing regimen is very complicated. And there's no set regimen. Each doctor does things a little bit differently. Most of the time, because our patients respond to it differently, but it adds to just a significant stress in how we treat nephrotic syndrome. Of course, our treatments have a lot of side effects. Overall, they all suppress the immune system. They, particularly steroids, Prograf, they can cause hypertension, they can affect obesity, growth delay, they can produce brittle bones in our patients, affect your behavior and mood, cause cosmetic changes. Some agents affect your fertility. Some medications you cannot take during pregnancy because they're harmful to the fetus. We often prescribe more medications to manage the side effect of our main treatment medicines and also to protect you against nephrotic syndrome complications. And these include Bactrim that you would take to prevent infections or sometimes IgE therapy. We often recommend routine vaccinations, and you may need additional boosters and more expanded vaccinations. A lot of our patients are on blood pressure medicines, calcium and vitamin D supplements, and for women, we definitely should be talking to you about contraceptives. And not only are our medication treatments complex, as you well know, there are other additional management tasks that can also significantly impact your lifestyle. So we're all familiar with the low salt diet, much easier said than done, particularly in a little toddler. That's very hard to do. But it is important to prevent swelling and also helps minimize your hypertension. Eating right, reducing the fat intake, increasing fruit, vegetable, and fiber is really important to counteract that steroid side effect, but also nephrotic syndrome itself causes high cholesterol level. So eating right is super important. Low-fat dairy products are important to maintain bone health. Of course, exercise and activity, and also frequent doctor's visits. So this is incredibly burdensome. And for a lot of our patients, additionally, we really would love to have their urine checked at home very frequently, because it allows us to pick up disease relapse and remission based on how much protein you're spilling or your loved one is spilling. But there are several issues. First, the definition of relapse or remission is very hard for a lot of our patients to understand. Urine checks are really difficult, nearly impossible for some of our patients that are still in diapers, and also very difficult for our elderly patients. This urine dipsticks are hard to read. I have a lot of patients with visual deficits, or it's just simply hard to find and read the correct test squares. I can't tell you how many times I've had families purchase the wrong test strips, or test strips of bad quality, or they read to me the wrong test square. And guess what? None of the strips are covered by insurance, and this cost is really prohibitive to a large proportion of our patients. And I think it's incredibly disturbing that we can't give patients urine test strips. So the management burden, again, I don't have to tell you, is incredibly high. And I really appreciate this mother. She posts periodically about her child's experience living with FSGS. Here she is showing you just the number of pills that her daughter has to take. And what is the impact of all of this? The hardships of living with nephrotic syndrome can really impact and affect our patients' well-being. So when we look at, when we study this, our patients on average have lower quality of life compared to others. There's higher likelihood of developing depression and anxiety. There's higher reporting of impairments in social, emotional, and physical functioning. The next bullet point is pediatric data. Nearly all of our children are hospitalized at least once. Hospitalization rate is quite high, 0.5 per 2 hospitalizations per patient per year. It's extremely costly to, and this point I stress to a lot of anytime I have to fill out an insurance appeal form, I talk about just the cost savings in terms of just giving our patients the right medicines versus hospitalization costs. And not only that, our patients have a significant proportion of these hospitalizations are complicated by very bad outcomes like septicemia, which is infection in your bloodstream, peritonitis, pneumonia, new onset diabetes, blood clots. So these serious complications happen quite often, and it's just incredibly important that we treat our patients adequately and prevent them from getting to that point. This is one of the studies we looked at, and again, this study uses the Neptune network. We followed 225 patients, pediatric patients with nephrotic syndrome for 3 years, and we surveyed them periodically on how they're doing taking the medicines that their kidney doctor prescribed. And then we look at how they're doing in terms of how many hospitalizations they've had, ED visits, and their response to treatment. And what we found is nearly 40%, so 36% of our participants say that they cannot adhere to or take the medicines appropriately as their doctors have prescribed. And this non-adherence to medication is associated with increased hospitalizations and emergency room visits and steroid resistance. I didn't find a statistical significance here, so I can't for sure say that this difference was not due to chance, but we did see that relationship. And so despite all this evidence that nephrotic syndrome really impacts our family, there is a lack of support for our families and patients. So these studies, next grouping of results are from surveys and interviews and focus groups that with patients and families with nephrotic syndrome. Our first finding is that information on nephrotic syndrome is poor, poorly available and of poor quality and not always relevant to our families. And the families, you can imagine when they read something that doesn't pertain to them, it produces unnecessary worry and anxiety. Second point is doctors do not have time to fully explain what the condition is or to adequately follow what is happening to patients. And this is coming from doctors telling us this and also patients. So when we survey doctors, 57% report that they don't learn about a disease relapse until patients have had bad complications. And 64% of doctors report that they inadvertently kept patients on steroids longer because they don't hear about disease remission from the families. Patients themselves, on the other hand, don't have information on the basics of this condition. So they have low self-efficacy, and self-efficacy is a term that just describes how confident you are and do you actually have the knowledge and tools to manage your condition. So there's low self-efficacy and increased worry and anxiety. So they don't know what causes nephrotic syndrome. A lot of them don't know what urine protein results mean and how you follow it at home. So of course it makes sense that a lot of times important relapses are not reported to the doctors, and families are really wanting to know what more can be done to take care of their condition. So it is, of course, to us imperative that we support patients and families in managing their condition. And I want to mention several possibilities that we have through using eHealth. And eHealth really is simply any kind of medical tool that uses a mobile device and an internet connected device. So this can pertain to your patient portal that gives you your results, help you connect with your doctor, telehealth visits, telemedicine visits, mobile apps, web apps. I really want to, again, thank NephCure for your wonderful website, which it has a lot of very great information out there that's accurate for our patients, and also social media. I've seen you connect via Facebook, via discussions online. So all these tools can be considered eHealth. And they are uniquely suited for chronic disease management, and I would argue for a condition like nephrotic syndrome. First, it delivers care to you that's easily accessible to you on your own terms, on your own time, removing kind of geographic or temporal barriers. And it provides many new ways of communication with your provider. I have lots of patients communicate with me via MyChart. And lastly, these tools have computing capabilities. So it's very easy for us to manage and analyze your data and provide you information that's individualized to you. So you're not receiving a bunch of distracting information, irrelevant information that worry you unnecessarily. So in nephrotic syndrome, we believe that eHealth can do several things that's specific. First, it can help read and analyze urine test strips. And second, provide timely individualized action plans on when to contact your providers and give you reminders. Again, our medicines are very complex. So reminders for medications, urine checks, and follow-ups. It can definitely link you better with your provider so we can communicate more directly, transmit your information seamlessly to your provider, and provide alerts to both the provider and patients. And finally, again, educate our patients and families on the disease, on the basics of the disease that they really need to know. And all of these elements fall within the elements of a validated chronic care model that describes all the necessary components to produce improved clinical outcomes. So in the next few slides, I'll give you specific applications that we have created and studied for use in nephrotic syndrome. The first is a text messaging program that we deployed through Neptune. So this is the Neptune SMS program. And again, thank you for your participation if you or your loved ones is in this study. So in this study, we sent text for the first 90 days and then weekly for 9 months. And on the bottom right is a screenshot of what the text message would look like. It asks, for instance, what is your child's urine protein today? And families text back a simple number to indicate their response. We also ask about symptoms, quality of life, potential relapse triggers, and whether or not they're able to adhere with the medications. And what we gained from this program, so we followed 127 patients in this study with, who are children. We sent text, as I've mentioned, for a whole year looking for those results. And what we found is that overwhelmingly our participants agreed to participate. So they accepted this extra text messaging program very readily. 94% agreed to it. And the median response rate is 87%. Throughout 1 year follow-up. So that's great. And our results have high concordance with same-day clinic findings. Most importantly, it allowed us to pick up many more relapses versus what we would otherwise pick up through communication, traditional communication means. So using text messaging, we picked up 108 relapses versus just 41 relapses by clinical reports. So this is fantastic. And we are also able to pinpoint much earlier when our patients go into remission. So just imagine the power there to prevent disease complications and also to prevent patients from being treated unnecessarily longer than they need to be. And so that's really given us a motivation to create a more enhanced tool. So this is our effort to create a mobile app that adds additional features to the text messaging program. So in your app, what we did is first we had a group of experts come together, myself included. We drafted features that we think would be helpful to our patients. And the panel included nephrologists, engineers, and behavioral science experts. Then one of the features we created was a camera read of the urine test strip, which I'll show you in a bit. And then we took the prototype and tested it with patients and their adolescent patients and parents, and through multiple rounds. And based on their feedback, revised and refined the URAP prototype. And so here are the final features that we've included. Panel A on the left is the camera feature. So what you would do is you turn on the app and the camera and you aim the camera at your urine test strip. The app finds the correct urine protein square and reads the results for you. If you've relapsed, it analyzes your urine protein trend and sends an alert to you that you may have relapsed, and same if you've newly achieved remission. And it says contact your provider, and you have also the ability to send the test results to your caregiver. And other features, we color-coded the urine protein results in green, yellow, red, so that the results are more intuitive and easier to understand. We've embedded videos and Word documents, pictures in the app for some basic information on the condition. And on the very right is reminders that you can set up through the app to take your medicine or check your urine for protein. Currently, we're studying this app in a NIH-sponsored trial with 60 participants, and we will form a stakeholders committee to review the results of this trial to figure out if the use of this app is actually helpful for patients. Outside of this trial, the app is available for free download. So our ultimate goal is to develop a comprehensive tool to support patients and their families in partnership with patients, doctors, and engineers. And I've mentioned I received grant funding from NephCure Kidney International as well for our efforts. This is a joint effort between my institutions and Georgia Institute of Tech. We currently have funding and are currently working with adult patients, the CureGN Study Network, providers and patients at University of Michigan to develop a tool for adult patients with nephrotic syndrome. So that concludes my talk. I have some summary slides here. Please bear with me, they're fairly text heavy. Nephrotic syndrome is likely caused by a complex interplay of genetic, immunologic, environmental, circulating, and podocyte factors. Our disease management consists of complicated medication regimens, close monitoring of disease relapse and remission, monitoring and treatment of disease complications, as well as treatment side effects, diet and lifestyle changes, and frequent clinic visits. The burden of disease management adversely affects patients and caregivers, leading to lower quality of life, self-efficacy, and medication adherence. And suboptimal management leads to delayed relapse detection and treatment, as well as prolonged exposure to medication toxicities. Hospitalizations and severe complications are frequent. eHealth tools allow for care delivery in easily accessible platforms, removing geographic and temporal restrictions, increase ways for patient-provider communication, and provide individualized and pertinent care information. These attributes may be helpful in supporting nephrotic syndrome management. And there is evidence that eHealth tools are welcomed by patients and caregivers living with nephrotic syndrome and may improve disease activity tracking. I have a lot of collaborators and definitely want to acknowledge them on this page and want to thank the Neptune, CureGN, and PNRC Research Consortia. And importantly, all of you, patients and caregivers, that this is everything that we do is to help our patients with nephrotic syndrome. And I really want to thank your support and definitely want to thank my funders, including NephCure Kidney International. And I want to thank NephCure for the invitation today and your attention very much. We definitely would love to hear from you. Below is my contact information, and I welcome any emails or messages from you as well. Thank you so much.
Wonderful. Thank you so much for that amazing presentation. As you were going through, I just kept thinking, oh, that's important. Oh, I need to write that down. We need to share that more. We need to, so it was just full of really great information. Thank you so much. I want to remind everyone that we are taking question and answers. So if you have any questions, please feel free to type those into the Q&A box. And I'm just going to start with the top question here. I've read that with minimal change disease, scarring doesn't occur during a relapse like it does with FSGS. Is that the case? Or does scarring always happen with any relapse regardless of minimal change disease? Oh, you're muted.
Sorry about that.
That's okay.
Sorry.
It's a story in my life.
Chat box and you're right. Still can't figure out Zoom. Scarring. Thank you for the question. So we know that prolonged uncontrolled spilling of urine protein does scar the kidney, regardless if you're starting off with minimal change condition. So as you know, we don't biopsy our children very often. And so maybe just once at diagnosis, if that. So it's hard to pinpoint the exact amount of scarring that happens with each relapse. However, we do know that with prolonged unchecked proteinuria, you will end up with scarring. And not to mention, even before that, you're losing a lot of proteins that make you susceptible to a lot of the complications of nephrotic syndrome, like infections, bad swelling, and of course, blood clots and kidney injury. So yes, it does happen.
Great, thank you so much. And something that we try to reiterate at NephCure is that protein is an emergency. If you're spilling protein, that needs to be addressed. And while some of our patients are unable to achieve remission, a lot of times, especially in adults, proteinuria isn't taken as seriously as it should be. So that's a great question. Next question is from another attendee. Our 5-year-old was diagnosed with steroid-dependent minimal change disease 2 years ago. He's currently on 0.5 milligrams per kilogram prednisone every other day, which keeps him in remission. Do you believe that is a safe dose to keep him on long-term, or should we consider second-line meds?
Yeah, thank you. So that 0.5 per kilo every other day, we have pretty good evidence that that seems to be a fairly well tolerated dose that shouldn't impact you significantly. So if it works great, I think that's a very good viable option. Of course, you know, every child is different. Some children are, or every patient is different. Some are much more sensitive to medicine. So that frequent screening for blood pressure, growth, your own input back to your doctor about your child's own behavior, how they're learning in school, all of those factors need to be taken into account on whether or not this is the right regimen for him or her.
Yeah.
Sorry,
it's a him. Yes. Thank you so much. Yeah, I too have a child who is on actually daily low dose prednisone, and I think that every other day is ideal. The only other thing that I would mention is to make sure you talk to your nephrologist about at least being seen by an endocrinologist to see how that dosage is impacting his adrenal glands, because it doesn't necessarily take a lot of steroids to suppress those adrenal glands and impact the body's ability to produce cortisol in an emergency type situation. So that's something that I always point out, because it happened to my daughter where she deals with a little bit of adrenal insufficiency because of that consistent dose of steroids. Okay, the next question is about stimulating the vagus nerve. Do you have any experience or are you familiar with a study out of New York City with positive results in 7 pediatric patients?
Yeah. And so it's very exciting. This investigator has recently received NIH funding to study this particular treatment, and I believe she is setting up this randomized trial. So that's something that just happened within the last year, and I'm excited and really very much looking forward to the results. I have not done it myself. This treatment is not widely available outside of research settings.
Do you want to just explain a little bit about the vagus nerve and where it is in the body?
Oh gosh, so I really don't understand very much about it,
Okay.
or really understand how it would work. Just because it seems very unrelated to the immune system that we've
Yeah.
discussed and all the factors we've discussed. So if the proposed mechanism is true, then it would be outside of everything I've just presented to you, and
Right.
adding another layer to nephrotic syndrome pathogenesis. But yes, that study should be being set up.
Wonderful. We'll have to keep an eye out on it. Thank you for
Yes.
bringing it
Yeah.
up, Marie. Doris has a question about supplements, and this is actually a really good question because it comes up frequently, and it's always important for patients to check with their nephrologist about different supplements. But her specific question is, would supplements like, I don't know how to say that, chitosan, activated charcoal, probiotics, prorenal, D+, etc., help with nephrotic syndromes? It seems like a lot of people with CKD say these help with their creatinine.
Yeah. So we differentiate a little bit with a nephrotic syndrome that is sort of we're still trying to manage the active phases of nephrotic syndrome and getting into remission, versus when nephrotic syndrome has already caused some permanent and irreversible injury to the kidney, so that our creatinine has been impacted some. So there is some differentiation of what the supplements are for, if you're using it to control the active nephrotic syndrome or to promote your kidney function and maintain good kidney function. So there definitely you listed several, and of the list, there is no firm research on them specific to nephrotic syndrome treatment. Definitely check with your doctor. In general, I think some principles I want to point out is in general, most of those supplements are not well proven, and generally herbal or nutritional supplements are not regulated by the FDA. So we always want to think about the quality of the supplement that you're getting. So so we definitely want to check your doctor about that. Some of the supplements that claim to be mega doses, you particularly want to be careful because a lot of as you know, the kidneys are your filtering powerhouse. So if you are taking mega doses of anything as advertised mega doses, we always, as kidney patients, want to take an extra close look. Even something like mega doses of vitamin C sounds great, but it's bad for kidney patients because, you know, it can actually lead to kidney stones in our family. Creatine supplements, I do not recommend. It's just an extra sort of protein burden on your kidneys that is already kind of managing this high flow of protein out of those delicate filters. And probiotics is one where you've mentioned. I don't have any specific, don't know of any good studies that link probiotics with beneficial outcomes in kidney disease, in any CKD or in nephrotic syndrome. So I think in general, what I would point out is that sometimes the most common eat your fruits and vegetables, eat balanced meals, simple kind of regimens that have been proven to work are the best. A lot of other additional supplements may be simply ways for you to spend money. So do want to be careful about those.
Wonderful. Well, thank you so much. We are out of time. I want to thank all of our attendees for joining us this afternoon, and I want to send a special thanks to Dr. Wang for joining us and the wonderful presentation. And we're so thrilled that you're making really good use of the funding that we've provided, and we're so proud to be a part of it. So thanks again for your time today, and I hope everyone has a great rest of your Wednesday.
Thank you.